All right, welcome, Dr. Farid. If you can, please provide your name and title and what procedures you work on.
Wonderful. Thank you for having me. My name is Marjan Farid. I'm a professor of ophthalmology and the director of cornea, cataract, and refractive surgery here at UC Irvine. So the surgeries I do are multiple. I do probably the largest volume of surgeries I do is cataract surgery. We also do a variety of corneal transplants. I do severe ocular surface disease and ocular surface reconstruction, as well as I also remove a lot of things from the ocular surface, cancers of the eye. So anything sort of related to the front of the eye, I do.
Thank you so much. And what's important to know about all the disease conditions that can lead to the necessary procedures that you work on?
So let's talk about cataract, for example. Cataract is, a natural process of aging. And so it basically occurs in 100% of patients who live long enough. I usually tell my patients, if you have gray hair, you've got cataract. So it sort of starts at the age of our mid 40s, where our lens starts to stiffen and it gets more dense with age. And some patients and families and genetics and diabetics tend to get more visually significant dense cataracts earlier in life. And some patients will go to their grave with their cataract because it never becomes dense enough to become visually significant. So super common and something we deal with, as the aging population increases, we deal with that more and more. Corneal transplants are a different story. So corneal transplants, there's a variety of reasons we do corneal transplants. Corneal scars on the eye, infections of the cornea that leave a scar behind. Then there's a lot of genetic dystrophies of the cornea that require corneal transplantation. So there's some dystrophies where some people are born with a lower number of corneal endothelial cells. This is a dystrophy called Fuchs dystrophy, and they end up needing a corneal transplant. And this type of corneal transplant has really evolved over the years. So where we, started doing full thickness transplants, now we can do partial transplants. So we can get into that a little bit too.
Great, thank you so much. And what's been historically done, especially for cataracts and corneal transplants? You kind of mentioned a little bit about it.
Yeah, so historically, cataract surgery, years and years ago, centuries ago, the way it would be done was called a procedure called couching, where, basically it would be a white dense cataract where you could see it from the outside. And, they would basically push really hard on the eye and dislocate the lens into the back of the eye, and it would sort of float around in the back. And the patient would go from seeing nothing to now seeing a little bit more, getting light in at least. So that's how it initially started centuries and centuries ago. Obviously, we've come a long way. We now not only take out the cataract, but we replace it because it's the natural lens of the eye. So we replace it with an intraocular lens. Cataract surgery probably, over 50 years ago, it was done where we would open the eye really, about a 12 millimeter incision, take out the cataract hole. Patients would stay in the hospital for several weeks with sandbags around their heads. There were no intraocular lenses even at that time. So they'd have to have these big, thick Coke bottle glasses on afterwards. Over the years, about 50 years ago, there was the sort of invention of phacoemulsification, which is essentially ultrasound technology that can break up the cataract and then vacuum it out at the same time. So now we could go to smaller incisions where we didn't have to open up the eye into a big incision. And over the years, that phacoemulsification technology itself has really advanced, where we've gotten to being able to do cataract surgery through a 2.4 millimeter incision. And the intraocular lenses have advanced so that they're foldable. So you can roll them in through that same 2.4 millimeter incision. They roll into the eye like a taco or a taquito, and then they open up inside the eye and sit where the natural lens used to sit. So now it's gone from a several hour surgery down to a 6 to 7 minute procedure, which is how I do them.
Wow.
That's cataract. Yeah.
What about corneal transplants? Maybe
Yeah.
you can tell us
So
about
corneal
that.
transplants similarly have gone through a really nice evolution. So, you know, corneal transplants, again, decades ago, patients would have to wear a pager because, you know, they'd have to wait for somebody to die in a hospital. That organ would be harvested. The patients would have a pager that would say, okay, we'll go off. We're ready to do your surgery now. We have a donor. They get it right off of the freshly deceased cadaver and then transplant it onto the patient. Then the advancement there was the development of something called Optisol, which is a fluid that where you can harvest the donor from patients, harvest the cornea from donors who have recently passed. And now that cornea can sit in Optisol for 7 to 14 days. So now we have eye banks. We have eye banks that go around and harvest corneas from patients who are dying in hospitals and getting, you know, organ procurement, if you will, and then putting those tissues through a series of tests to make sure they're good, they're viable, they've got good cell counts, they're, you know, go through an infectious disease panel to make sure they're clean and so on, and then they're ready to be transplanted, but now they're good for at least a week, right? So patients don't have to wait with a pager. I just schedule a patient and the eye bank has a tissue available for me because they're constantly procuring and storing these really good donor tissues. So there's advancement in donor procurement and storage. The other advancement is we used to do full thickness transplants for every disease pathology. Now we really do what we call partial thickness transplants, that because if my problem on the cornea is on the surface, I don't need to transplant my entire cornea. Similarly, if my problem on the cornea is on the inner layer of the cornea, why am I transplanting the entire cornea? So now we've gone to disease targeted corneal lamellar transplant surgery, so partial thickness. So again, now patients who have that Fuchs dystrophy, we can do just give them a layer of cells, which is small incision, and we can do that through a very small 2 mm incision as well. So we've really advanced, you know, going to disease targeted corneal transplant surgery. We also use lasers in corneal surgery and cataract surgery now to help make some of the incisions for both cataract surgery and corneal surgery. These are called femtosecond lasers. They're very ultra fast lasers that can make very specific cuts at specific depths within the eye. And they're programmable, so the cuts can be very specific shapes that you wouldn't be able to make with a regular blade. So lots of advancements in that area as well.
Great. And so you mentioned a few of them, namely the fact that donor procurement doesn't seem to be a problem anymore, which is amazing, as well as being able to focus on specific diseases and using lasers. What improvements have been made on these different fronts for looking at specific disease conditions or using specific advancements in different types of laser technologies that are being done today?
Yeah, there's so many advancements in all of these areas constantly. We have really great industry backing up the ophthalmic community. So there's constantly innovations being made, phacoemulsification machines every few years, and there's competing companies who are just constantly outdoing each other, smarter and smarter ultrasound technology, smarter and smarter and faster lasers. And diagnostics, the ability to look at these disease states in a more comprehensive way, to be able to look at the different layers of the cornea, to really being able to hone in on the exact problem. So both on diagnostics as well as therapeutics, we're seeing super advancements in all of these areas. Intraocular lens technology. So there used to be my conversation with patients when I started doing this like 15, 20 years ago was, you're getting a lens, you're going to see, you're going to change your glasses prescription. Now patients can come out of their glasses altogether. We have lenses that correct astigmatism. We have lenses that are multifocal technology for patients who don't want to wear their glasses anymore. We have light adjustable lenses where you put the lens into the eye, and then after surgery, you can adjust the power of the lens with ultraviolet light. So really cool technology advancements that are just like blowing my mind away daily.
Great. And so you mentioned quite a few. I wish I had the intraocular lenses, but it's definitely, where do you see this going in the future? Say, 10 years from now, what do you think improvements can be made so that we can get to a point where nobody ever has to worry about their eyesight?
Okay.
So sorry, just to recap, where are we going in 10 years so that nobody has an eyesight problem ever again?
Yeah, I don't think we're going to be to the point where we're going to cure all corneal cataract and ocular surface issues. But there are, in 10 years, we're going to have one of the biggest advancements that's actually in the works now is injectable endothelial cells. So again, for those patients who have a corneal dystrophy and who right now need a partial thickness transplant, right now we have one donor treating one patient. What they're working on now, which is early in its development, is taking one donor cornea, taking the cells of that cornea, expanding them in a lab. So now that one cornea can treat hundreds of patients, right? Because one of the problems in the larger developing world is there's a shortage of corneal donor tissue. So there's many patients who are corneal blind who can't get donor tissue. Maybe, the culture does not, patients who die don't really donate. So there's a lot of cultural issues, but you just don't, or you don't have corneal surgeons. So part of that issue is there's a shortage of corneal tissue worldwide, not here in the States, but worldwide. So being able to take one donor tissue and now being able to treat hundreds of patients, that's huge, right? So we're going to see that advancement in the world of corneal surgery anyways, and corneal transplants. For cataract surgery, it's becoming more and more precise with our power measurements, so that when a patient has cataract surgery, we're going to be in the goal of aspiring every patient to have that perfect 20/20 vision, right? Without the need for glasses. We're almost there. Like 97% of patients, we're able to target the power we want and achieve it, but there's still some patients who fall out of those algorithms of power calculation. So we're going to get more and more exact with that. Intraocular lens developments and the decreased dependence on glasses post-operatively is a big push. So we're going to see less glasses, I think, in the future. And
Oh,
all
no.
Yeah.
Oh, great. Well, thank you so much. And my very last question that I have for you is just, what advice would you give to medical students or biomedical engineers that are aspiring to work in your field?
Yeah, it's a great field. I mean, it's so fun to be in ophthalmology because it's a really good mix of, surgical care, patient care, and then technology and innovation. And I think maybe more than any other field, if you love innovating and sort of, and I know biomedical engineers probably do, that's what you guys do. It's a really fun field to be able to just continue to advance these technologies and lasers and diagnostics, and it's just a fun place to be. So good luck to everybody, and I know everyone will do well.
All right. Well, thank you so much.
Sure. Thanks.